How are treatment strategies changing for low risk and high risk patients with MPN?
So complicated because we need to think across the entities, and we don't have an answer to that for patients with MPN unclassified, and we don't actually have a good answer to that for this entity called pre-fibrotic myelofibrosis, which does appear and is strongly recognized in the new diagnostic criteria. But for ET, for example, low risk patients I mentioned, triple negative, calreticulin positive, young patients, platelets less than 1,500, not too much changing there. Queries about aspirin or not. And then for PV patients, we haven't really changed our kind of high risk criteria. And for both ET and PV, the question there is, should we use a treatment above aspirin or above aspirin and venesection? And for the most part, that would be hydroxycarbamide or hydroxyurea, which is the commonest treatment used worldwide, or interferon. And these are the right treatment for some patients and not the right treatment for other patients. So some patients can be very fixated on interferon is the absolute best, but there is no clear evidence of that. And there are some patients for whom interferon is not the right treatment. But low versus high risk becomes even more important for myelofibrosis patients. And here we're thinking about using a risky strategy like transplantation for those patients who have higher risk disease. And we're using, as I mentioned to you, these molecular markers and newer prognostic tools to stratify patients. And it's important to remember as a patient that if someone puts your data into a prognostic tool and it comes out with 5 years, that doesn't mean to say 5 years on the dot, your time's up. That's an average. And if we put your data into a slightly different tool, we might get something else. So for the most part, we make decisions about transplant. We're learning more about transplantation and outcomes from that. And then in some countries, some treatments are used for patients who fall into intermediate or high risk categories. And some clinical trials are based on that as well. What I would want to say about myelofibrosis, and something I think I would really like to see changed, not changing yet, but changed, is that we should be able to intervene for patients with low risk disease. If my myelofibrosis patients had breast cancer, we would not be going, there, you've got low risk disease, we'll put you on watch and wait. Watch and wait is really hard for our patients. We know that. I can see you nodding, Nicole.
Yeah.
I think you know that too, right? So if these were patients with breast cancer, we would not say we'll just watch and wait. So I would really like to see in the next 5 to 10 years a treatment that we could use earlier in the disease course, but there is nothing at the moment, but we're looking at that. The other thing we're looking at, if we've got a minute or so, is different endpoints. So we're trying to understand what does it mean if your allele burden, so the amount of abnormal gene you've got goes down, the amount of bone marrow fibrosis you've got goes down. And again, this is something we'll collect in a clinical trial, but also from real world data.